Welcome everybody to SRH Access. We are live with Drs. Carl Rathjen and Scott Oishi. Thank you guys for joining us. And today we're going to talk about arthrogryposis. And as always, we're taking live questions, so feel free to jump into our conversation at any time, and we're going to get those answered for you. So first, I just want to ask you guys, what is arthrogryposis and how does that affect the body?
So arthrogryposis is kind of like saying you have a car. There's a lot of different types of it. It comes in all kinds of different shapes and sizes and affects all kinds of muscles. And there are some things that may not be classic arthrogryposis, but get called that because it's the closest thing that it looks to. In its most classic form, arthrogryposis is actually a neurologic condition that involves the anterior horn cells in the spinal cord, and it produces weakness. And then that weakness produces stiffness and contractures of the extremities.
And I think the definition of arthrogryposis just means, it's a very general definition, right? So that just means curved joints. I mean, really what we treat a lot here is what's called amyoplasia, which is lack of muscle. And so it affects the joints and, it affects the muscles in which the joints get very stiff. And it has a very classic appearance. They even see it sometimes on ultrasound in about 16 weeks of age. Although that's fairly non-specific, they can see very characteristic, arms extended and, the legs in a certain position. It's missed about 70 or 75% of the time, but occasionally they do see it on real-time ultrasound.
And that was kind of something I was going to talk to you guys about next. Is there something parents should be looking for? How is this diagnosed typically?
The diagnosis is really, like Dr. Rathjen was saying, it's a clinical diagnosis. When you've ruled out other sort of things, neurologic or myopathies and things like that, amyoplasia is more of a sort of a clinical diagnosis.
And again, in the most classic form, they have very characteristic features in the upper extremities, where the shoulders are internally rotated, the elbows are extended, the wrists are flexed, and then they have varying involvement in the lower extremities with the feet and the knees and the hips. And then a lot of times a very classic form will also have a little hemangioma right in the middle of the forehead, which kind of fades over time.
And the question that parents always ask myself, and I'm sure Dr. Rathjen, is it genetic? And so the classic form that we're talking about here is the amyoplasia, where it affects the upper and lower extremities from the shoulders down to the hands and from the hips down to the feet. And that form is, as of now, is not thought to be genetic. It's more of a sporadic. Some of the forms that affect primarily the wrist, distal or past the wrist to the fingers and the ankles to the toes, called distal arthrogryposis, certainly does have a genetic component to it. But this more generalized form that we frequently see affecting the upper and lower extremities from shoulders to fingers and hips to toes, for right now does not have any sort of genetic predilection, although people are looking at it very hard now to see if there really is some sort of genetic mutation. There is none that we know about now.
So important to note, there is just this wide range of differences for kids with arthrogryposis.
Yep.
Yes.
And are there other health conditions that come along with arthrogryposis that people should be concerned about?
Well, health conditions really, when you're treating a kid with arthrogryposis, if you're going to have surgery on them, they need to be at a sort of a specialized children's hospital, for the reason that anesthesia can be very difficult in these children. They have sometimes stiff jaws, or they sometimes are difficult intubations, difficult IV access, and most importantly, because they lack muscle, they do a lot of the anesthetic drugs by weight and by muscle mass, and so these kids may get overdosed because they don't have enough sort of muscle.
The other problem, particularly when they're young and you're having an anesthetic, is they may not, if they're weak, they may not breathe well. And so they may have some weakness even in their ability to breathe, which can cause secondary complications. But from a long-term perspective, when you look at chronic medical conditions and really independence and lifelong function, they usually have normal or above normal intelligence. And so they're very bright, engaging. So if you have a baby and they have arthrogryposis, you wonder, when are they going to talk and when are they going to do all these other milestones? And intellectually, they're usually normal.
And I wanted to talk to you guys, you touched a little bit on treatments, surgery, physical therapy. What are some of the treatment options for a patient that comes here with arthrogryposis?
Well, what we start with is, obviously a great examination, full body examination to make sure that's what the diagnosis is. And because of the contractures, therapy is really important, because I think, a lot of studies we've done here and also nationally, internationally show that there's a catch-up period. So in the first 8 months to a year, with a lot of stretching, whatever muscle has, is there, they can make stronger, and the joints can get more flexible. So, I mean, that's the way we obviously start in the upper extremities. I'm sure the lower extremities are very similar.
Absolutely. We'll start, the club foot is probably the most common feature of the lower extremities, and we'll start treating the club feet really probably in the first month of life with serial casting. And if they have knee dislocations or stiffness of the knees, we'll often incorporate that in the treatment. And again, trying to get as much range of motion in the feet and the knees as you can accomplish, in those first 6 to 12 months.
And if a patient comes here when they are 6 to 12 months, parents bringing their babies here, is this something you guys see them for throughout, their life until they're 18, or what does kind of that look like for you guys?
We see them together. Usually, I mean, if one patient comes to see me for the upper extremities, the same day we make sure they have an appointment to see, one of the partners that does lower extremity, for example, Dr. Rathjen, and we sort of coordinate care, and certainly until they're 18. But that often involves occupational therapy, physical therapy, child life issues that they get as they're growing up, but we certainly see them until they're 18.
Dr. Rathjen, you were touching, this is kind of the team approach that we have here that sets us apart from some of the other hospitals.
Absolutely. It is certainly, it is treatment that is best, I think, best delivered by a team that sees it frequently, because there's a unique cadence of things that you start to recognize over time, and there's a time where you need therapy, and there's a time where you may need surgery, and then just helping families prepare for that emotionally, and then afterwards, kind of coordinating the process of rehabilitation. And then I think we try to be very family focused and very child focused. A child with arthrogryposis is still a child, and we want to provide them all those opportunities that children have, whether that's play, whether that's camp. We have a weekend camp for families and kids with arthrogryposis. And so really throughout that period of childhood from birth to 18, we want to work with those families so that child, whether they have severe arthrogryposis and a lot of trouble moving and need mobility aids like wheelchairs, or whether they have very little weakness and they really function pretty normally. We want to help each family reach their highest potential and maximal function.
And as you guys know, touching on this a little bit, we posted a video yesterday of one of our arthrogryposis patients, Tanner, and he's now running for Team USA Paralympics. We had a lot of parents commenting about how inspirational he was and how they were so surprised at what he's accomplished. And I wanted to talk about limitations and expectations. What would you say to parents who just got an arthrogryposis diagnosis?
The first thing I think I tell them actually is that every case is different. So out of the box doesn't come the same toy every time. And so every child you have to cater to, what their specific physical findings are. And our goal is really to let them do whatever they want. I mean, there's no real limitations. The limitations is just what they can do.
Yeah, I think one of the things other people are surprised, and I think that a parent of a 1-year-old would be surprised to see an 18-year-old. But by the time a child with arthrogryposis is 2, the family quits being surprised and amazed, because that's their normal, right? And that's the normal for that child, and it may be different and it may look different, but they still will celebrate successes and struggles like children that don't have arthrogryposis.
And I think one of the things you touched on, the family approach, patient approach, on that video, some of the parents were saying, oh my gosh, contact me, and I'm happy to let you know Tanner's parents are reaching out to younger parents, and I feel like that speaks to the community that we have here.
Absolutely. We have such a strong, good support group here for parents and for patients. It's great.
Yeah, and I think that, peer-to-peer or family-to-family, I mean, one of the things that I tell families a lot of times is that there's nothing that is better than talking to another family, right? Because they've lived it, right? And I mean, our perspective is skewed. I mean, we know, we can see the long-term perspective, but in the day-to-day, how do you kind of get through things? Right. Another family is probably the best source.
Is there a topic that most parents come? You mentioned, parents always ask this question. Are there things that you feel like maybe parents who are watching, you would want to answer for them that are top questions you get about arthrogryposis?
Not really. I mean, I think the real thing is they want to know what it's going to look like when they're 18. And it's so difficult to say because every child is different. I mean, we do everything we can to maximize their function. So for us, it's to be able to get all the ADLs, called ADL, activities of daily living, putting shirts on, doing their hair, buttoning their pants, things that we take for granted. We try to do whatever we can to facilitate that, whether it's therapy or whether it's surgery or whether it's both of those.
Yeah, and I think reiterating that, every child is different, and it can be, it's a huge spectrum, from kids that may, play club sports in high school to kids who are using a wheelchair and maybe even need help breathing at night, right? So there's a vast spectrum, and when you are talking to other families or talking to other people, really trying to understand if the weakness, because I think the underlying feature that is hard for us to restore is how much weakness there is, and so if there's strength there, the function is going to be more normal than if the weaker you are, the more difficult I think things will be. And kind of, so if you're talking to another family to understand where is their child relative to your child and the amount of weakness or the residual strength that's left.
Lastly, I just wanted to talk about research. What kind of research does our hospital have with this patient population?
I think as far as upper extremities goes, we've done a lot of research as far as looking at long-term outcomes. Because everything nowadays is about, you can do a procedure, but what does it do 10 years from now or 20 years from now? And so we do a procedure that brings their wrist, usually their wrists are flexed like this, and we bring them up into a sort of a neutral position, called a neutral position, but straight, so they can do these kind of activities palm to palm and not cross fashion. And it seems to help them to get their hands to their mouth and just do things better. And so we've looked at them both short-term and published it actually long-term. Long-term data that exists on that condition, and right now we're working also on elbow flexion, because like Dr. Rathjen was saying, if you lack active motion or ability to get your hand to your mouth, it's difficult. Whereas if you can do a tendon transfer, it's called tendon transfer, move a muscle around to give them that, it would be an incredible help for them. So we're looking at that in our long-term data right now on that.
I think, on the lower extremity, our probably two areas of research it's all clinical research. So looking at the outcomes of treatment, and we look at the outcome of treatment of the club feet, and then of spine deformity or scoliosis. And it's something we haven't really touched on very much, but a number, perhaps as much as a third of patients with arthrogryposis will develop scoliosis. And so, and if they develop that in the first 6 years of life, it can be quite a challenge to treat, to make sure that the lungs are able to grow and you have normal pulmonary support. And so, again, having kind of one center and one team of therapists and anesthesiologists where you can treat the spine and the lower extremities and the upper extremities together is it's fun for us because we get to know the families more and care for them in a comprehensive fashion.
All right, I think that's pretty much it for us, unless there's anything else you guys want to add.
I don't think so.
Oh, thanks so much.
Touched on
Thanks
all
for
kinds
having
of
us.
things. If you have any questions, still feel free to post those. We'll get them to these guys and they'll get them answered for you. And be sure to join us next week for our next episode of SRH Access.